perfect.
All right. Hi, everyone. I'm Krishna Patel. I'm one of the cardiologists and a multimodality imager. I recently joined Sinai. It's great to be here and talk about CAD evaluation. I know the chiefs assigned me a topic of outpatient ischemia evaluation, but given kind of new developments over the past few years, I felt a more appropriate discussion would be how would we go about evaluating a patient who comes in with stable type chest pain, which would include both looking for ischemia and sometimes even just looking for anatomic presence of disease or plaque. So chest pain, right? Chest pain is the most common complaint that we all see in our internist clinic or even in cardiology clinic. Probably 60 to 70% of the patients, at least in cardiology clinic, they all come in with some sort of vague chest pain. We have new chest pain guidelines that recently came out a few months ago. So I have kind of incorporated that throughout this talk and kind of will highlight some of the differences that this particular guideline has compared to the older guideline. You know, whenever we do evaluate chest pain, you know, it's not only you're not only looking at the symptoms, but whenever you're talking to the patients, you're trying to assess what the pretest likelihood of coronary artery disease is. And when you do that, a question is, do I think that this chest pain is related to the heart, or is this because of coronary artery disease, or is this because of something else? We used to use this term atypical chest pain, typical chest pain, and non-cardiac chest pain, but we are now recommending against using the term atypical. We know that women have chest discomfort, but they also can have other symptoms such as nausea, vomiting, dizziness, which we used to say that these were atypical symptoms, but they're not necessarily atypical. They're typical for women. So now we're recommending to use the term cardiac, possibly cardiac, and non-cardiac. So when you have a patient coming into your clinic and is reporting some sort of a chest pain, we kind of evaluate the quality of chest pain that the patient's having, and then categorize that into, hey, I think this is possibly cardiac related, which is more central pressure, tightness or heaviness type of pain, more exertional in nature. Sometimes could be dull or aching, versus this is more likely a non-cardiac pain, which would have, you know, more like pleuritic kind of chest pain symptoms. Once you have that in mind, then based on that, you want to try and assess in your mind, hey, what is the pretest probability of coronary artery disease that this patient has? And based on that, you will decide what test you want to order, or whether or not you do need any diagnostic testing in a patient to figure out what is going on. So our goals with testing for a patient who comes in with new onset chest pain is, first, we want to determine how likely is this from coronary artery disease. And second, we want to try and confirm the diagnosis with testing if indicated. Traditionally, in medical school, what we learn, you know, using Diamond-Forrester plots, typicality of chest pain, age to determine the pretest likelihood of disease. But we now know that classification does tend to overestimate disease prevalence. And why do we say that? It's because as over time, over the past 2 decades, as our treatment has improved, as more and more patients are on preventive medications such as aspirin, statin, with newer therapies, they're less likely to have ischemia. And this is seen in multiple studies, national studies, where people who, out of everybody who undergoes like either like a stress test to look for ischemia, only about 10% actually do have evidence of ischemia. This suggests that, hey, you know, are we really over testing? Do we really need to test everybody? And it's also seen in patients who actually are referred for cath. So, you know, these are patients where the physician is thinking, hey, this is really, really high likelihood of disease. Even among those patients, there is a very high rate of normal angiography. About 6 in 10 patients have normal coronary arteries. So how do you assess for pretest probability? In this new chest pain guidelines that just came out, they revised the estimates. The estimates of pretest probability. So now they recommend that don't think about chest pain as typical or atypical. Just categorize it into whether the patient's having chest pain or dyspnea, and based on that and the age, look at the probability. This is the nomogram that they're recommending that we use. And they and if you just look at it, really only patients who have, you know, old men essentially have a high pretest probability, which is defined as more than 50% likelihood of having coronary artery disease. But this is what they're asking us to use. But let's look at the low probability. So, you know, women less than 50 or less than 60 who have chest pain, and men less than 40 with chest pain and dyspnea. These are the patients who are at an extremely low likelihood, given their age, of having pretest of having significant coronary artery disease. So they should be kind of labeled as low pretest probability. And then once you kind of determine in your head, and this, you know, when you're talking to the patient, what the pretest probability is, try to look for other things which can help you choose one way versus other. So if the person's had an EKG, do they have any baseline EKG abnormalities? Do they have any other cardiovascular risk factors such as diabetes or smoking or dyslipidemia? All of those would increase in your mind the probability that the patient's having disease. If the patient's has had a chest CT for whatever, to rule out PE, look at the chest CT to see if you see any calcium in their coronary arteries, because if you do, then that increases your pretest probability of coronary artery disease. And why is this important? This is important because, you know, now that the prevalence of disease in the population, as it decreases, you tend to have more kind of false positives. So the negative predictive value of a particular test, you want a test which has a high negative predictive value, which helps you rule out disease so that you don't over-test. All right, so this is what the guidelines recommend. So you first look for symptoms and, you know, look for the other kind of clinical information that you have available, including cardiovascular risk factors, type of symptoms, ECG, anything else that you have. And then based on that, make a determination. Is this patient really unstable? Then you don't really, you know, then you follow your acute coronary syndrome guideline and send the patient to the ER. You don't really need to do anything else. Then you try to assess the pretest probability, and based on that, you can choose what diagnostic test you want. So for somebody who has a lower likelihood of coronary artery disease, you want to try and rule out disease. You want to make sure that this is nothing significant. So you want a test such as coronary CTA, where you're looking for plaque, you're looking for obstruction, because that test has a very good likelihood to help you rule out disease. If the CTA is normal, then you can, or does not show significant disease, then you can say, hey, this is not, you know, the chest pain that the person's having is not from coronary disease. The other thing that a CTA can help you do is also figure out, hey, does this patient have evidence of plaque, calcified or non-calcified? So it can help prompt you in terms of starting preventive therapy such as aspirin, statin, and the likes. And then for somebody who has a little bit of a higher likelihood of coronary artery disease, you probably know that, hey, you know, this patient probably has coronary artery disease. Now, the question does not become, hey, is this coronary artery disease or not? You also want to know, hey, do I need to do anything with this? Do I really need to send this patient to cath, or what do I need to do with this patient? So when your likelihood of disease increases, you want to try and choose a more kind of specific test, such as ischemia, where it would tell you, hey, the symptoms that the patient is having is from ischemia, and based on the extent of ischemia and what the result is, it can help you guide what you want to do next in terms of whether you should send this patient for revascularization or treat this patient medically. So that's how you should think about what test to order. So in the new guidelines, now they recommend that once you've done this initial assessment of patients' clinical risk, for the low risk patients where you don't really think that this patient has a high likelihood of disease, they actually went ahead and said that do not test. It is okay to not test these patients at that time. It's somewhat controversial, but it makes sense, right? If you're not going to do anything with the test that you have, with getting a test, if you're just looking for a normal test, if you don't really think this patient has coronary artery disease, we have evidence which shows that it's okay not to order any test. The other thing they recommend is some people, who have, let's say, like a high family history, or who have all these risk factors such as HIV or adverse pregnancy outcomes, some non-traditional or traditional risk factors, but you still think that they're low risk. In those patients, you can consider looking at the calcium, even looking at a CT that is done for PE and looking for evidence of calcium in the coronaries, that can help you kind of decide whether or not you should go ahead and order some test or just like stop there. Similarly, you can also use exercise ECG alone in some patients where you still want some testing, but you think that the patient is low risk enough. So let's look at a couple of examples. So on left, we have a 40-year-old woman presented with chest pain. She had a couple of risk factors. She has a history of HIV and a family history of coronary artery disease. However, her lipids, blood pressure, everything is well controlled, and she presents with some retrosternal chest pain that keeps coming back off and on, and it has not been resolving, and she's concerned about that. The ECG, you do an ECG in the clinic, doesn't really show any major abnormalities. And then on the right, you have another man, again, kind of young to middle-aged, 45-year-old man. He has hypertension. He is able to exercise, but he's having dyspnea on walking a few blocks. And his baseline, you do a baseline ECG and it's normal. So these two patients, I would say, are more on like the low range in terms of the pretest likelihood of coronary artery disease, or maybe lower range of intermediate, low to intermediate range. And my goal of testing in these patients is I want to make sure that this is not significant coronary artery disease. So I want to choose a test with high negative predictive value. So in these patients, I think if they didn't have any risk factors, you could just not consider testing at that point, and that would be fine. But given that they have a couple of risk factors, you want to choose something like a coronary CTA, which helps you rule out disease, is any significant disease. The other option that you have is also, you can also do exercise ECG, especially because it gives you a lot of prognostic information in terms of how the patient would do over the next few years. Imaging is not necessarily recommended for these patients. However, I'll show you examples of when we would consider adding imaging along with just a treadmill test. So in this 40-year-old woman, we did a coronary CTA, didn't really see any plaque or any blockage. here, so this was sufficient, and now we kind of ruled out any disease in this woman. We were comfortable saying that, hey, the pain that you're having is not from um, significant epicardial coronary artery disease. The other thing that we noticed on her on her CT scan is we saw a small hiatal hernia. So now that made us think, hey, is this what she's having? Is she having like symptoms of reflux? And she ended up getting evaluated for it, and her symptoms resolved with PPI. If this patient showed some plaque, that would have helped too, because now that the plaque is not going to cause her symptoms. However, given that she has had she's had the plaque has started to form, calcified or non-calcified, we would have started this patient on aspirin and statin at least for prevention, to make sure that the plaque doesn't progress. So CCTA is helpful for both things. In the man, we ended up just going with an exercise ECG. He did well. He exercised for 13 minutes on a Bruce protocol, up to 100% of his max predicted heart rate. His exercise capacity was very, very good, 15 mets. And then there was no chest pain or any symptoms on exercise, which necessitated stopping of his chest pain. Blood pressure response was good. And overall, we look at a score called Duke treadmill score, which was normal and low risk. So exercise ECG in this patient helped us say that, hey, the prognosis of this patient, the likelihood that this person's going to have an MI or die from coronary artery disease over the next 5 years is very low, and you could just stop right there. But as you know, it doesn't give you information on whether or not there's plaque or not. So that is how you use the information that you get in these patients. When would you consider combining an exercise ECG with imaging? When you have a more kind of intermediate Duke treadmill score. So Duke treadmill score looks at how much time you exercised, what are the whether or not you had any angina or chest pain with exercise, and then also looks at the STT changes. So if there was some abnormality in either of those, then you want to combine it with some imaging to make sure, look for, because it's more sensitive to pick up disease. In patients who already have, that they have some calcium or some evidence of known coronary artery disease in the past, you never want to do exercise ECG by itself. You want to always combine it with imaging, because exercise ECG has false positive rates. Patients who have any baseline ECG abnormalities, and we'll talk about those are the patients you want to order a treadmill with something, with imaging, either with an echo or with myocardial perfusion imaging with PET or SPECT. And more in like patients who are intermediate to high pretest risk, never do ECG alone. You want to try and add on imaging with it. All right, let's talk more about exercise ECG. In the last guidelines that came out in 2012, exercise ECG used to be class 1 for patients who had suspected and or known ECG. If the patient can exercise, we would always prefer an exercise ECG with or without imaging to look for a disease. Now we do know that the accuracy of just a treadmill only is lower compared to other functional and anatomic tests such as CT or stress testing. So now in the most recent guidelines, it has been downgraded to a 2A recommendation. So unless the patient is extremely low risk and you just want more assurance that that it's okay to defer testing, exercise ECG alone doesn't play a role. And if the patient can exercise, and if you do want to go that route, you should combine it with either a stress echo or a stress SPECT to get for more sensitive detection of CAD. Again, the sensitivity and specificity is more kind of moderate for exercise ECG alone for diagnosis of obstructive CAD. It should especially not be used for any patients who have had some sort of a baseline ECG abnormality. If you see a left bundle on their ECG, or the patient has a pacemaker, or there is a Wolff-Parkinson-White syndrome and a delta wave that you see on your EKG, or some sort of STT abnormalities, those are the patients you don't want to do exercise ECG alone. You want to combine it with testing, but for left bundle and pace rhythm, you actually want to choose vasodilator test or choose a pharmacologic test over an exercise test, and I'll tell you why. But exercise does give us good prognostic information. The amount of METs you can do, patients with who can do more than 10 METs, they have very good prognosis. Again, this Duke treadmill score, as I said, takes into account a bunch of different things. But if the Duke treadmill score is normal or more than 5, then that portends a very low risk group with a very low short-term mortality. So you don't necessarily need to do anything, but it gives you good information on how the patient's going to do over the next few years. What are the high-risk findings that you see on an exercise ECG? And the reason I put them in here is because when you let's say you order a treadmill test on one of your patients and you get a report, I want you to look at these things and see if any of these are present, because that would help you look at some of the individual components of the exercise test which are associated with high risk. So if you see ST depressions more than 2 millimeters or STT changes at a low workload, so, more than 10 METs is good response, but let's say somebody can only exercise for 5 to 6 METs and started to have some STT changes then. Or when the STT changes kind of lasted long in recovery, those are the concerning those are the concerning things that you see on an exercise ECG, which make you think, hey, I need to do something else and maybe probably refer this patient for angiogram. Another important thing to look for is the blood pressure response. Normally, the blood pressure would go up if you have a significant drop in blood pressure with exercise, or once your exercise is done, your heart rate is slow to come back to normal. Those are the things, these are the factors that are associated with poor prognostic risk and should prompt you to consider further invasive testing. Again, exercise-induced arrhythmias such as VT are also on there. So we talked about low risk, where you wouldn't do testing, or if you wanted to do it, you can consider using calcium score or exercise ECG to guide you one way versus the other. But most of the patients that you're going to see in your clinic are more, are going to be a little bit older, at least the ones that we see in cardiology clinic, a little bit older, have some sort of a risk factor, hypertension, dyslipidemia. So they fall in the more kind of intermediate to high risk category. Previously, we used to say high risk should go for cath. In the new guidelines, for patients who don't have any known coronary artery disease, they kind of club the two together and recommend imaging testing as first line to diagnose disease before you would consider directly referring a patient for cath. You have two options. You can choose either a coronary CTA, or you can choose stress testing, and both are good options. And as I said, we look at other things to help us guide, hey, should I choose a stress test in this patient, or should I choose coronary CTA? Before we talk about stress testing, let's talk about some of what are we trying to diagnose, or what are we looking at, some of the concepts behind stress testing or ischemia. So as we have increasing stenosis or increasing burden of plaque, which would restrict the blood flow to the myocardium, these are the sequence of events that occur before occur when you have ischemia. Sorry, I should rephrase this. So whenever we have ischemia, or whenever there is decreased blood supply to the myocardium, to the heart muscle, these are the sequence of events that occur in the patient. So the earliest change you would start noticing is you would start noticing an abnormality of flow that goes to one part of the heart versus another. This is what we look for when we do a MPI study or a SPECT study, myocardial perfusion imaging study. We're trying to look for differences in flow. And then as ischemia gets worse, or as the blood flow to the myocardium is jeopardized, you start getting diastolic dysfunction, then you start seeing wall motion abnormalities before you start seeing ECG changes, and eventually the patient will develop rest angina. What a coronary CTA helps us do is we can look at the anatomic extent of disease within the epicardial lumen of the coronary artery. And what our stress tests help us do is look at the consequences of ischemia in a patient. So a nuclear test is more sensitive because it picks up early changes in the ischemic cascade, versus something like a stress echocardiogram, actually, where we look at changes in wall motion abnormalities, is more specific because it is looking for changes that happen a little bit later in the ischemic cascade. So what happens when you have a blockage in your coronary artery? At rest, when the demand of the heart is not high, there is a phenomena called coronary autoregulation. What it does is, unless the stenosis is very severe, like more than 80-90%, at rest, the patient would not, it actually, you can have normal blood flow to the myocardium because the demand is not high. So the vessel actually dilates and auto-regulates its flow. However, it cannot do that when the patient exercises because the demand of the myocardium increases when on stress. So at rest, the coronary flow is about 1 milliliter per minute per gram of tissue. And whenever they undergo any sort of activity or exercise, then the flows go up to 2 to 4 ml per minute per gram. And when there is a stenosis, when you stress a patient, that is where, like 50-60% stenosis, your flow starts to fall down, unlike rest where you need really critical stenosis. And this flow disparity is what we use in stress imaging, stress nuclear imaging. We try to image this to look for ischemia. So this is just another kind of graphic which helps explain this. So at rest, even when you have significant stenosis, you could still have normal flow because the requirement is not that high. So the coronaries can adjust the flow so that your heart will get, all the parts of your heart will get good blood flow at rest. However, when on stress, when you vasodilate, when you increase the heart rate and increase the demand of the heart, the area of the heart that is supplied by the coronary, which has a significant stenosis, the flow increases by 3 times in the normal part, but it cannot increase proportionately in this area, which is subtended by a stenotic artery. So the flow would be lower in that area which is supplied by a stenosis versus a normal area. And this is what we're trying to image. We give a radio tracer that goes to the heart proportional to the blood flow to the heart, and we then image the heart to look for this lower flow to a section of the heart versus the other. And that is what we refer to as ischemia when we say this patient has ischemia on their test. This is what we're trying to image. So not necessarily looking at the oxygen supply of the heart muscle itself, we're looking at the flow disparity. All right, so intermediate to high risk of coronary artery disease. If the patient can exercise, it's okay to choose exercise stress because you can get good prognostic information from an exercise ECG. In addition, when you combine it with an imaging modality such as a stress echo or a stress nuclear. When would you choose pharmacologic stress? First, when the patient has arthritis, cannot really exercise to a good workload. So to have a diagnostic exercise test, the heart rate pressure product, so that is like the multiplication of your heart rate and your blood pressure. So the patient has to exercise to at least 85% of their maximum predicted heart rate for a test to be diagnostic, to be very sensitive in terms of ruling out disease when you combine it with imaging. So for somebody, you think that, hey, I don't think this person can exercise to a good workload, is going to get tired after a little bit of time, or has some arthritis, or cannot exercise. Those are the patients that you should choose sending them for a vasodilator stress test or pharmacologic stress test over just an exercise stress test, because it would be non-diagnostic and then it would be converted to a pharmacologic stress. When the patient has severe aortic stenosis or hypertrophic cardiomyopathy or an aneurysm, that's when exercise testing has a relative contraindication. So those patients, if they need testing, stress testing, should undergo pharmacologic stress. Similarly, with left bundle branch block or pacemaker, what happens is, because of the way the conduction system is, patients with left bundle branch block or pacemaker, when they undergo exercise, they actually can have false positive imaging test. Their imaging can become abnormal just because of the way that the heart moves. So those are the patients that you actually want to just go ahead and do a vasodilator stress on those, and not do an exercise test with imaging. And then other patients who run digoxin, again, because of their baseline STT abnormalities, we would choose pharmacologic stress over exercise. We could use either vasodilator, which is what is used in a stress cardiac MR and stress nuclear. So we use regadenoson, adenosine, and dipridamol. What these agents actually are adenosine and agonists. So what they do is they increase the blood flow. Regadenoson is selectively to the heart, and some of these are non-selective. So dipridamol actually also has some peripheral effects, but that's what we're trying to do. We're just trying to increase the blood flow to the heart, and that's what's used in nuclear and MR. You can also use dobutamine, which is what is used with echo when the patient cannot undergo exercise echo. Dobutamine is a beta-1 agonist, so it increases the pumping function. It increases the ejection fraction, or the pumping function of the heart. It's a good agent, but patients often complain a lot because it causes more palpitations. It's not a pleasant agent. So that's why kind of dobutamine stress is not favored unless the patient has severe asthma or something that we cannot use these other vasodilators. So we typically, if you need pharmacologic stress, we prefer a vasodilator pharmacologic stress. When we look at the diagnostic accuracy of the different options we have available for patients without any known CAD to detect obstructive CAD. So this was a study where they took 200 patients. All patients underwent all tests. They didn't undergo stress echo, but they underwent a PET nuclear, they underwent a SPECT nuclear study, and then they underwent a coronary CTA. And then, as a gold standard, they underwent an invasive angiogram with fractional flow reservoir, FFR measurement, which actually tells us that whether or not a lesion that you're seeing on your cath, is that physiologically significant or not? Is that causing ischemia or not? So with that as a reference gold standard, over just clinical risk factors alone, which is this light gray line, all the three tests performed well. The best performance was the best diagnostic accuracy was seen in patients who underwent a PET nuclear test, followed by SPECT and coronary CTA, where the accuracy was about 74%. So what factors would you consider when you want to choose one test versus other? This is what the guidelines recommend. They're very high level recommendations, but something to keep in mind. When your goal is to, as I said, when your goal is to rule out obstructive disease, or where your goal is to detect non-obstructive disease so that you can start preventive medications such as aspirin and statin, then you should choose coronary CTA. Again, you want to make sure that it is available at your institution. We have both, we have good quality CTA as well as good quality stress imaging available at our center. So, it's not a problem here, but the local expertise also kind of matters. Typically, CCTA is used in more kind of younger patients, because you want to, again, these patients are at a lower risk for having very extensive disease. So you want to just, you're trying to rule out disease. You also want to use it when you've had a prior stress test and it has, it's like not inconclusive. And then you want to use stress imaging when you have, in older patients where your CCTA is inconclusive and where you're suspecting more extensive disease. So patients who have already known disease, they have a prior stent or a prior bypass surgery and now coming to you for symptoms. Those are the patients where you want to try and use stress imaging test. And we'll talk about the CMB and stuff a little bit later. I'm going to skip this for the interest of time. The other thing that the guidelines also recommend is when the patient has no known CAD and is undergoing a stress test, we should add a coronary artery calcium score on top of the test to give us more information on subclinical atherosclerosis, which we can treat medically with aspirin and statin. So for PET. So for a PET nuclear test, we actually do CT scans on all our patients because we use it for the test. And we commonly would add a coronary artery calcium score on top of the nuclear test to give you the information on atherosclerotic disease as well as functional testing. And the other thing that they recommend is if you have both PET and SPECT available, you should, at your center, you should choose PET over SPECT. And recently we've started PET service at Morningside. So, so if you do have any appropriate patients who are more like higher risk, now it is available at our center for you to order and choose. Again, these are the things that you would think about when you want to choose a PET nuclear versus just a regular nuclear test, which is traditionally done with SPECT. PET is a newer technology which offers you better spatial resolution, better diagnostic accuracy with very low radiation. So the radiation exposure with PET is like significant, like 3-fold lower compared to traditional SPECT. And the other good thing with PET is that we can actually not only look at the relative change in perfusion, like I told you, but you can actually quantify. I can actually say, well, this is the blood flow that is going to this part of the this area of the myocardium at rest, and this is what it is at rest. So the ability to quantitate the myocardial blood flow actually opens up. We can diagnose things like microvascular disease and also look at more extensive disease versus traditional imaging. So it's preferred when somebody, so PET is typically done with vasodilator test just because of the technique and then the radio tracers that we have. They're very short-lived, so we have to combine it with pharmacologic testing. So we typically recommend it in patients who are not able to exercise because if they're exercising, we should get prognostic information from the exercise. It's also recommended for patients who have, large breasts or are obese, where you do know that the quality of the test, if you do a stress echo or if you do a SPECT test or a SPECT nuclear test is going to be compromised. even a CT in very obese patients, leads to higher radiation exposure, and the image quality is not that good. So those are the patients where we would recommend actually going for a PET nuclear test versus the other. We also recommend this in like more high risk patients. When you're worried that this patient has more extensive disease like left main disease or multivessel disease, that's where you would want to choose a better test. So something like a PET nuclear test over a SPECT. In patients who already have known coronary artery disease. So these are the patients that you're not diagnosing coronary artery disease. You already know that they have coronary artery disease. They have calcium on their coronaries, or they have had a cath before which showed non-obstructive disease, or they've had a coronary CTA in the past which did not show any, which showed some stenosis. So what do you do when these patients come to your clinic with chest pain? So here you want to try and think about whether the disease that you already know that the patient has, do they have non-obstructive disease or do they have obstructive disease? So non-obstructive disease is when, let's say, somebody has some calcium on their scan, or they've had a cath in the past which said 30-40% stenosis. That's when you want to, you can, for testing, if you want, consider a coronary CTA, versus somebody who has known evidence of obstructive disease. So these are patients who had like bypass surgery in the past, or had some stent in the past, or they have a lot of calcium on their coronaries. When these patients come in with chest pain, either you should send them directly for a cath if you think that the chest pain is very typical and this patient needs to undergo revascularization, or you should consider stress testing in these patients, where because the question is not whether or not they have coronary artery disease, the question is whether or not you should do anything about it. The important thing to realize, which is a change compared to older guidelines, is now we know with the ischemia trial that most patients with coronary artery disease, we can treat them with just optimizing their medical management. So the first step before thinking about testing is to actually look at what medications they're on. Are they on an aspirin? Are they on a statin? Are they on beta blocker, ACE inhibitors? And optimize them first. And if they continue to have symptoms on good medical therapy, that's when you actually want to consider testing, because you already know that they have disease. So you're going to treat them medically. And the question for testing is only when, only if you want to really, send them for revascularization versus not. So first thing, in patients with known coronary artery disease, check whether they are on good medicines for their coronary artery disease. And if they're still having symptoms on that, that's when you would choose either a coronary CT or a stress testing based on how extensive their disease was, for further testing and management. The other important thing that is important to recognize is everything that we spoke about. We're focusing on blockages in the coronary arteries. We're focusing on epicardial disease, meaning you're seeing a coronary, you're looking for blockage or plaque or anything within the coronary circulation. Now we do know that these are the coronaries. This is what we can see on cath. This is what we can see on coronary CTA. But majority of the blood supply to the heart, or the change in blood supply or the demand of the heart, is regulated by the microvessels or the microcirculation. You can see here. These are very, very small arterioles and capillaries that supply the muscle of the heart. And these, and you cannot see them, on any imaging test. So you have to, to look for any abnormalities within the microvasculature, you have to actually use sophisticated imaging and specialized physiologic testing to look for disease in the microcirculation. What we know now is that this blockage stuff that we talk about, that only accounts for about 30% of disease. And now overall majority of the patients with ischemic heart disease actually have disease within the microcirculation, within these kind of small little vessels which we cannot see. These patients typically have risk factors such as smoking, they're obese, hypertension, diabetes, cardiometabolic risk factors. These are the factors, these things, they affect the microcirculation, and they would still cause similar symptoms of angina and chest pain, but you would not be able to tell just based on, your cath or coronary CTA. So you'd often see patients, they're labeled as false positive, meaning that they're having chest pain, but their cath is negative, or their coronary CTA is negative. So that does not mean that they have non-cardiac chest pain. You should, especially in the right context, if these patients have risk factors and stuff, think about, hey, maybe the person has a problem in the microcirculation, and we should recognize this and then test for it appropriately. So this is what has been referred to as INOCA, patients with ischemia with non-obstructive coronary artery disease on their imaging, meaning the cath or coronary CTA did not show any blockage, but they continue to have symptoms of ischemia or angina, and previously they were labeled as false positives, but no, that's false positive, but that's not the case. These patients may have disease of the microcirculation, and for these patients we have a couple of options now. Either you should consider referring these patients to angiogram, where they do special tests to look for these things. It is not available right now. It's not commonly used. It's only used in about 10 centers across the entire United States. But in the next few years, this will become commonly available everywhere, including our hospital as well. But right now, that's not an option. But that's one thing you could do. The other thing you can do is look for, do a study which actually allows you to quantify the blood flow. So a stress PET nuclear test or a stress CMR, with a specialized sequence. So we have stress CMR, but we don't have the research sequence to measure flow. So currently at our hospital, these patients will probably be candidates for a stress PET nuclear. And what that does is when we look at the actual blood flow, we can identify whether or not they have disease of the microcirculation or not, which help explain the symptoms of these patients. And then also we can manage them appropriately with ACE inhibitors, beta blockers, and all of that that help improve microvascular disease. We only have a couple of minutes, so I wanted to just quickly show you a couple of examples and then talk about the take-home points. So this was a case of a symptomatic patient. He has known non-obstructive disease, has some risk factors, hypertension, dyslipidemia, presents with dyspnea on exertion for 3 to 4 weeks, and he can exercise. So now my question, so now I have, you can choose anything. You can choose a coronary CTA or you can choose functional testing. And for functional testing, because he can exercise, I want to try and use something with exercise, which would be an exercise SPECT or an exercise echo. So this patient underwent an exercise study and he did have these ST depressions. However, his exercise capacity overall was normal. Was good at 10.1 mets, and these are his nuclear images. So the stress images are on top and the rest images are on bottom. So here you're trying to look for a difference. Is there less flow on in any area of the heart on stress compared to rest? That's not the case. This is a normal study. So overall, this patient, if you'd only have done an exercise ECG, we would have, send this patient to a cath. The cath would not have shown any, significant disease, and the patient would have been labeled as the false positive ECG test. However, the imaging here actually helped us. And overall, given that he has good exercise capacity and normal imaging study, we can say that he's low risk for having significant obstructive disease and that he does not really require any further testing. He's already on good regimen for his coronary artery disease, which should be continued. Let's look at this other patient. So this is another patient. He does not have known coronary artery disease. He has multiple risk factors: hypertension, dyslipidemia, diabetes, obesity, doesn't have good exercise capacity, also presents with chest pain. Here also you can choose anything. You can choose either a coronary CT or a stress test. Here for this patient, we ended up, given he was like higher risk, intermediate to high risk, given all of these risk factors that he had, we wanted to choose, and he was also like a little bit on the older side. We ended up going with a stress imaging strategy over a coronary CTA strategy. And this was a PET that was done on this patient. So PET actually gives you information on the calcium, because we do a calcium score on this patient. So it showed us, oh, there's a lot of coronary calcifications. Here, looking at the images, stress on top, rest on bottom, we see that here in the right side, right coronary territory, in the inferiorly, there is low flow on stress compared to rest. It suggests that, oh, maybe there is an RC, significant disease in the right coronary artery, that may be explaining what the patient's symptoms are. And with the PET, we actually, because we get the information on the flow information here actually tells us that even when we're just seeing that there's the inferiorly, that the RCA territory is involved, the flows are actually depressed everywhere in all three coronary territories. So it actually helped us, this information, the flow information along with the calcium score information, made us think that maybe he doesn't have disease only in the right side, he has disease in the LAD and the circumflex as well. So we sent him for a cath, which confirmed multi-vessel disease. And then eventually the patient underwent cabbage and was doing well. So this is how stress testing and PET versus PET can help in terms of not only helping us localize disease, RCA, but this says that it's probably everywhere. It actually helps us understand the extent of disease, that this patient has multi-vessel involvement, looking at the flows, and helps us in diagnosis of disease, but it also helped us guide our management. Because there was significant disease and decreased flow everywhere, this patient was referred for bypass surgery. And then this third case is a case of, again, a middle-aged female with multiple risk factors who keeps on coming back over and over to the clinic with chest tightness, shortness of breath, fatigue. You've already done a coronary CTA in this patient, and which showed just mild non-calcified plaque. And you already started the patient on aspirin and statin, but she keeps coming back with her symptoms. So this is the patient where you're like, okay, it's not that these symptoms are non-cardiac, but given this risk factor history and given how she keeps coming back with symptoms, maybe this person has microvascular disease or disease of the microcirculation. And that's when you would consider referring this patient to cardiology for further management. And cardiology, what they'll end up doing is, given that this is a suspected patient with INOCA or ischemia with non-obstructive coronary artery disease, we would either choose to do a stress PET or a stress CMR or a physiologic cath. Currently, we only really have stress PET available, so that's what we would do. And in this patient, we see that the perfusion image is normal. There's no calcium because she had, as we remember, she had some non-calcified plaque in her LAD. However, the flow information actually tells us that her flows everywhere in her heart, when you stress the patient, they're all depressed. The flows don't go up appropriately. So the PET study in this particular instance actually helped us diagnose disease of the microcirculation. And then we started the patient on beta blocker ACE inhibitors, which actually helped microvascular disease. And that eventually led to improvement in her symptoms as well. So the main take-home points, whenever you have a patient in your clinic who presents with chest pain or dyspnea and you're thinking about coronary artery disease, is first assess the symptoms. Figure out if the symptoms, are you going to classify them as completely non-cardiac symptoms, or could they be cardiac related, possibly cardiac related, or definite cardiac related symptoms? When you're choosing testing in patients, there's no one size fits all. You have to try and choose different tests based on what your clinical question is. And here is where the pretest clinical likelihood of the patient based on their age, their risk factors, and other information can help you. In very low risk patients where you don't think this is cardiac related, you can consider not testing at all. This is a new thing which should help decrease the over testing in these patients. Sometimes you can consider a calcium score and exercise ECG, but again in lower risk patients to help guide your decision regarding testing. When would you choose a coronary CTA? When the patient is younger, more on the lower end of the intermediate likelihood of disease or low to intermediate disease. When patients have non-obstructive CAD without significant calcium, what does it do? It helps you identify non-stenotic plaque, which should be treated medically, and it helps you rule out disease. It helps you rule out, hey, epicardial coronary artery disease is not the reason why this patient is having symptoms. When would you choose stress testing? With patients with multiple risk factors who are more on the high end of the spectrum, where you know that they probably have coronary artery disease, you also want to know with your test, should I do anything about this? What does a stress testing do? It helps you identify whether obstructive disease inside the coronary is the reason for why the patient is having symptoms of ischemia. And it also helps you guide your management as to whether or not you should do anything about this. Where available, you should combine this the stress testing with a coronary artery calcium score to identify subclinical disease. And this is what we do, especially with PET at our institution, because it's routinely available on the same scanner. And then for like high risk patients, you should consider a PET over SPECT for all the things that we discussed, who have large breasts, when you're concerned about poor image quality, obese patients, or where you're concerned about more significant disease or microvascular disease. And then in patients who already have known disease, such as prior PCI or CABG, you want to first optimize their medical management for their coronary disease. Make sure they're on aspirin, hydrostatin, beta blocker, ACE inhibitors. And then if they're still having persistent symptoms, you choose either coronary CTA or more likely stress testing to help you decide what should be done next. And then the other important thing is, instead of labeling patients who have a normal cath but have symptoms concerning for angina or dyspnea on exertion, instead of saying that this is non-cardiac, think about possibility of INOCA or ischemia with non-obstructive coronary artery in these patients, especially if they're having cardiometabolic risk factors such as obesity, hypertension, diabetes. And in these patients, consider referring them to cardiology for more specialized evaluation of microvascular disease. All right, if you have any questions, I would be happy to take them. And please feel free to reach out to me with any questions, or if you have any patients that you're not sure what to do next, I would be happy to help you with that.